Good morning, everyone. Happy Friday. Thank you for joining me today as we talk about comorbidities in dementia. I'm going to let a few more of y'all in. All right, everyone's in. Good deal. So thank you for joining me. Again, as I said, today's information, it's not going to be super packed. Hopefully, I'll be able to get through it a little quicker than normal. But I do want to give this information because a lot of you are caring for loved ones who have dementia. And there are a lot of things that can coincide with dementia that I think are important for us to be aware of. Of course, not everybody is going to have the same experience, but there are a lot of things that happen with dementia that I think if we're aware of before they develop, or maybe they have already developed and we're thinking, this is just um, part of the disease, having that information can help you navigate the care. It can maybe help you advocate a little bit more for your loved one and bring things to the doctor that maybe you wouldn't have associated with a comorbidity. So that again, that can help maybe potentially help the treatment process a little bit too. Before I get into the information though, if you're interested in participating in the post survey, please put your email address in the chat. I'll send you the post survey after. And this is just an opportunity for you to give me your feedback on this presentation and also give me any tips or ideas for future presentations as I develop this information for you. That being said, if you do have any questions or comments throughout the training, you're more than welcome to put them in the chat. These trainings are recorded, and so if you unmute and start talking, the camera will automatically put you on, and that will be put on our YouTube channel. And a lot of you don't want to be stars of the video, and that's perfectly okay. But I do want you to have the opportunity to ask questions, and so you're welcome to unmute and ask, but if you'd rather not be on the YouTube, just go ahead and put it in the chat, and there will be some time afterwards for us to have a discussion as well, okay? Also, I am a therapist and I am a caregiver wellness advocate, but I am not a medical doctor and I am not a dementia expert in your dementia case. So if you have specific health questions that I did not cover in the training today, I'm more than happy to answer them to the best of my capacity. But if there are specific questions about your specific case, I would always redirect you back to the primary care provider for your loved one, and they can answer you with a lot more detail, finesse, and experience than I ever could because I'm a social worker, I'm a therapist, I'm not a doctor, okay? So what is a comorbidity? So a comorbidity is something that happens alongside of another diagnosis, okay? We're going to talk today about things that happen more commonly with people who have dementia than those without dementia. But I would suggest a good portion of all diagnoses have comorbidities. This is actually part of a series that I've done where I've done comorbidities with ADHD and autism and things like that. So comorbidity is not an exclusive dementia term, but in the framework that we're talking about them today, it will be dementia comorbidities, okay? So we'll just get right into it. The first one, epilepsy. This one actually surprised me, but once I researched it, I was like, oh, that makes complete sense, okay? So epilepsy is a seizure disorder, okay? And a seizure is a brief, unprovoked disturbance of consciousness, behavior, motor function, or sensation. Okay. So some people who have seizures, they go unconscious, right? They can't control their bodies for a brief period of time. And this happens more frequently in older people. But the likelihood of having seizures with someone who has dementia is increased compared to the general population of the elderly. And it's been suggested that many of these are like partial seizures. They're usually not detected. Okay, so your loved one can be experiencing seizures and you might not even be aware of it, right? A lot of times we think of the seizure like in like in the media, right, where it's kind of this violent thrashing that takes place, and that can happen, sure, but there are levels of this kind of like a spectrum of intensity, and there's many different kinds of seizures that come along with epilepsy. So your loved one may be experiencing these partial seizures, and you're expecting maybe this big cinematic thrash, and maybe it just looks like, where they're kind of staring off into space, or maybe a little bit of a tremor, and you might not realize that that's what's happening, okay? What causes this? Well, one possible cause is the interruption of electrical signals within the brain due to the changes that dementia causes. We all know that dementia is kind of the shrinking or the dying off of the brain tissue. And so when that happens, the functioning of the brain becomes incapacitated in a lot of ways. And so it makes sense that if there's disruption in the brain and how it works, that the electricity that we get the signals going through our brain is going to be disrupted as well. Okay. Studies suggest that the younger onset dementia group, so people between ages of 50 and 59, have an increased chance of seizures than those who are diagnosed later in life. Okay. And seizures are often more common in people who have vascular dementia. So that would be like if you had like a stroke, you would probably get diagnosed with vascular dementia. Not saying that you will get vascular dementia if you had a stroke, but that's usually where it's linked. And seizures are more common in people who have that. People with dementia have a 6-time increased risk of having seizures, and they can occur up to 25% of people who have Alzheimer's disease. So what are some recommendations? Well, just consider the possibility that someone who has dementia may have seizures if they are falling frequently, fainting, or if they have moments where they're not really responsive to you. That could be what their seizure looks like. Okay, so that's when you just bring it up to your doctor, like, hey, I'm noticing these symptoms. Could it be a seizure, or could it be something else? Okay. People living with dementia often fall and have fainting and moments of unresponsiveness that aren't seizures. It's always good to rule that out, okay? They can be very difficult to detect. And if they are suspected, you just want to at least go to the doctor and see if they can just rule it out, right? Or see if there's anything else. If 2 or more suspected seizures have occurred, definitely go see your doctor, because they can give medication to your loved one that can maybe help so that they don't continue to have these disruptions in their brain. Next is delirium. Okay, so delirium is a condition of confusion that kind of happens. It's not like a constant thing. They call it acute confusion. And it usually presents with that rapid onset of altered levels of consciousness, disturbances in attention, orientation, memory, thinking, behavior. Okay, so they're kind of not themselves, right? And so there could be some erratic fluctuation that happens. What are the signs? Well, it can be that they're easily distracted. They have disorganized speech, periods of altered perception, so they're not really sure, like time, place, things like that. Restlessness or agitation, alternating with sleepiness. And they could be showing clear changes in their cognitive function throughout the course of the day, right? So they may start in one frame of mind and end in a different frame of mind, and that could be delirium. Okay. Let's see here. So there's also likely to be similar underlying mechanisms for dementia and delirium, including impaired sending and receiving of signals in the brain. Okay. So people who have dementia, they have a 5-fold increased risk of developing delirium compared to people without dementia. And it can occur in 22% to 89% of older people. So it's a big range. Okay, so of course, not everyone will experience delirium, but a good portion of those of our loved ones who are diagnosed with dementia are going to be at a greater risk of experiencing delirium. And it can happen for months at a time. And it can result in permanent memory impairment. And 75% of delirium cases occur in people with dementia. Okay, so that just means that people who do not have dementia are less likely to experience delirium. So, of course, if you think your loved one is delirious, if they are having a hard time orienting to time, place, and identity almost sometimes, and that's kind of like it happens suddenly, right? This isn't over like a long period of time where they're just slowly decreasing in that capacity. It could be like what they call, that acute delirium. Go to the doctor, okay? Go to the emergency room if you need to. If there's a sudden onset of confusion, right? Where mom was fine at lunchtime and then by 5:30, she just was not herself, right? Then we know maybe we need to go to the doctor right away, okay? This can also occur because of an infection. Okay, a lot of people don't know this, but having a urinary tract infection can send your loved one into a delirium. Fluid imbalance, right? Maybe they're dehydrated. That can cause delirium. Sometimes people are afraid to take their loved one to the emergency room if they're experiencing delirium because they're afraid their loved one's going to be restrained. But common practices are kind of moving away from that because they're finding that it doesn't really make anything better. Okay. But oftentimes when the straining happens, it is a safety protocol. Okay. So if that does happen to your loved one, of course, advocate for their well-being, advocate for what's best for them, but it could just be a temporary solution to a safety protocol that they have at the hospital, okay? Sometimes the medications your loved one is on can cause delirium, okay? We all know that sometimes medications meant to treat one thing can cause another problem, and so we have to be very mindful. If there was a medication switch right before this delirium kind of came in, bring that up to the doctor and let them know, hey, this could be what's causing it. Is there something else we can do, okay? A lot of the times, if your loved one is experiencing delirium, there is a specific like ward or place in the hospital that they will put them, and they have specialized care. They have people trained to manage delirium. And so that just may be something to be aware of. Okay, so I don't want you to freak out if you take your loved one to the doctor or to the hospital and they rush them off into this, other ward or other wing. There's people there that know how to treat them. Okay. And delirium can also be treated with short-term use of medication. Okay, sometimes it's a simple antibiotic. Sometimes it's a medication specifically for delirium. Okay. So there are options. The best case, though, best course of action is if you think your loved one's a little off and it's different from what you've noticed, definitely just take them to the doctor and get them checked out. Next one is falls. Okay, some people don't consider this a comorbidity or it doesn't come up on the radar, but it absolutely is because people who have dementia, they have a harder time moving their body, navigating the space that they're in. And so falls can be a lot more prominent. And it is a major health issue for most older people. A fall can lead to a downward spiral of immobility, right? Especially if they fall and they're frail and they break a bone or, throw something out of socket. That can actually get your loved one to be maybe like afraid of moving around on their own, maybe afraid of walking. And so they become more stationary, which can also impact a lot of their well-being and a lot of their functioning. And that can really change the trajectory, change the course of your loved one's ability to be in the home with you, okay? Studies have shown that dementia is associated with an increased risk of falls, which is twice that of someone who does not have dementia, okay? And so falls can refer to just losing balance and coming to rest on the ground. It doesn't mean just a complete, head over heels fall. They can just lose their balance and kind of, shift to the ground. And the increased rate of falls could be due to instability in their posture, impaired executive functioning, and impaired visuospatial skills. So that word just means how they see the world and how they gauge distance from objects. So, if you've been navigating the same floor plan for years and years and years, I'm not going to whack my knee on the coffee table because I can navigate around it without thinking too much, okay? Loved ones who have visual impairments or have a hard time gauging space, they could run into a coffee table that's been in the same place for 30 years, right? Because they can't judge the distance as well. And that can contribute to their falls, okay? And they can also occur due to the use of certain psychotropic drugs. And those are just drugs that are specifically for addressing mood and behavior. Okay, so a lot of your loved ones, they get to a stage where they need to take medication to help with their moods and to help with their expressions. And that can actually increase their risk of falls, right? So when a person moves from a sitting or resting position to a standing position too quickly, they can experience a pretty significant drop in their blood pressure, and that can make them kind of fainty, right? Make them more prone to falls. Okay, so falls are a big deal when it comes to dementia care, and I would argue with any type of geriatric care, falls are going to be an issue, but more so if your loved one has dementia. Okay. Some stats for you, they can occur at least once a year in about 70 to 80% of the people who have dementia. Okay, so you might not be falling every day, but falling once a year can really kind of muddy up the system as far as their recovery, right? Fractures in people with dementia occur 3 times more than the rest of the population. Okay, so you and I could probably fall and maybe we get a bump or a bruise, or maybe, we're a little sore for a few days, but we're pretty, good to go. People with dementia, people who are older, people who are frail, they could fall and break a major bone, right? They could fall and break a hip, they could fall and break a femur, they could fall and break an arm or a shoulder. And so that, of course, compounds the issue, right? They're not just dusting off the dust and moving on like, when you're younger. They can definitely put them in the hospital for a long time. Hip fractures are 3 times higher in people with dementia. And also, people are 3 times more likely to die within the first 6 months of that kind of an injury. Okay. So falls are not just bumps and bruises, they can definitely be dire in a consequence there. There's no interventions proven to prevent falls specifically for people with dementia, but there are things that you can do. Of course, review all the medications with the doctor periodically, make sure their blood pressure is where it needs to be, make sure that their food and water intake are what they need to be to go along with this medication. Review and treat postural hypotension. So that's just their posture and how they're able to get from a sitting to a standing position. Okay. You want to check their vision. Okay. See if they're losing capacity to see things the way that they used to. Because again, they could be walking into a room that they're very familiar with, but because their eyesight's getting poor, they might trip on a rug or trip on a coffee table or something like that. Exercise, if they are able to do it, particularly with strength and balance, can be very helpful. And then, of course, you might need some occupational therapy or some assessments. Sometimes people will come into the home and say, hey, you can't have all these rugs like this, or you got to make sure your shoes are out of the way, and like things that you wouldn't normally think about if somebody was well. But as the disease progresses, they can be little booby traps all around the house that you might not even be aware of. So sometimes people will come in and just assess your home for safety, and that can help prevent falls. Next, weight loss and nutritional disorders. Okay, so if you've been caring for someone with dementia for any amount of time, you know that nutrition can definitely be a hurdle. Their taste buds change, their capacity to chew changes, especially if you have a loved one who's had a stroke and it's been impacting the way that they can swallow. And so it's not uncommon for people who have dementia to experience weight loss and disorders because of gaps in their nutrition, right? So weight loss accompanied by malnutrition is one of the major signs of Alzheimer's disease and other dementias. Even in the early stages, weight changes can become apparent, and weight loss can even happen before they even get diagnosed. Weight loss is considered a significant comorbidity of dementia. Research has shown that malnutrition can increase the disease progression, right? It can make it happen a lot faster, and it can lead to death a lot faster, because a loss of muscle mass leads to a reduced overall function. So that, of course, if you're deteriorating physically, you're going to be more prone to falls and fractures, right? You're going to be more prone to ulcers and infections because your body isn't getting what it needs. There can also be an increased tendency to distraction, anxiety, agitation, especially if your loved one's constantly pacing. And this can have an impact on eating, okay? Dry mouth, ill-fitting dentures, gum disease, okay? This can all lead to problems with dentures or with eating. I know sometimes if your loved one is dehydrated, their dentures can fit a little looser and that can make it more difficult to eat. They could get mouth sores because of it. That makes them want to refuse food. They might forget that they like something and so they don't want to eat it, okay? And I know especially in the later stages, the sense of taste is so disrupted. Sometimes the only thing that they can taste is sweet. And so they're constantly wanting to eat sweets and junk food. Of course, that can lead to gaps in their nutrition as well, right? People with Alzheimer's have been known to lose up to 10% of their body weight over the course of the disease, which we might not think 10% is that big of a deal, but if you're already kind of frail or lower in weight or whatnot, that can definitely impact your capacity to navigate the disease healthily. And weight loss can occur up to 20 years before dementia starts to rear its head, right? Even if you have an adequate diet. So the best thing for you to do is just keep track, right? Keep a record if you can, just maybe monthly, right? How much do they weigh? And the doctor's probably doing this for you anyways, but it might be good just to kind of jot that information down. Increasing fluids, right? Dehydration is a big deal when it comes to eating and weight loss and all these nutritional disorders, right? If you're not producing enough saliva, if you got dry mouth, it can be harder to eat, it can be harder to swallow, harder to taste. If your loved one's refusing to eat, then we want to acclimate and we want to maybe adapt some of the things that we know that they're going to like, which I'm sure is kind of like, of course, that's what we're going to do. But some people might think that they have to go through this rigid diet because of all the nutritional things, and that's true. But if they're refusing food, we want to try to think, okay, what are things we know that they'll eat? What are some finger foods? Sometimes people just like to graze. They don't want to sit and do a whole meal. So just having little snacks around that are healthy can be really helpful. Give oral supplements 2 hours before meals, and visit a dietitian if necessary and see, hey, what can we do to fill in these gaps? Okay. They might not like spinach, but they enjoy oranges, and you can get a lot of the same vitamins and whatnot from oranges than you would from spinach. So you can always find ways to meet those nutritional goals without force feeding them lima beans. Okay. Incontinence. So this is the big one. A lot of people, when their loved one becomes incontinent, is when they start to increase the skilled care that their loved ones provide. And sometimes this is where people end up doing long-term placement outside of the home because it is it's a bigger deal than some of the other things that you need to do to care for your loved one, and especially if your loved one is not able to move themselves. Toileting and changing can be very, very hard physically for one person to do, and it just might not be an option for you anymore, right? So incontinence refers to the inability to respond appropriately when your body's signaling that you need to use the restroom, okay? So it can occur earlier in people who have vascular dementia or frontotemporal dementia than in somebody who maybe has Alzheimer's. Urinary and fecal incontinence in older people can cause great distress and lead to isolation, right? Because I've heard so many of you say, well, I can't do these things because of this, right? I can't go out and do shopping because mom might need to use the toilet every 15 minutes. And then she's very, doesn't want to do it. And so it's a very, it's a hard time, it's a hassle. So we just don't go anywhere, just don't leave the house, right? If that's your experience, you're not alone, okay? But changes in bladder and bowel function are very common in the older population and are due to a combination of disease, medications, and just their functional decline, right? They can't get the signals from the body to the brain to say, hey, we need to use the restroom, right? So incontinence in people with dementia is a combination of normal aging and impairments in those functions. Some medications can make it worse. Okay. Again, the medication, it's like this help harm kind of dichotomy we keep running into, right? Delirium, disorientation, and decreased levels of consciousness can also lead to incontinence, right? If your loved one is sleeping multiple hours out of the day, they're not getting up to use the toilet, right? So that can be a problem. If they're very disoriented, maybe they don't trust you, or they don't, they get into the bathroom and they can just tell you're trying to get their pants down, and they could not understand what's going on and think they're being violated in some way. So they want to fight you, right? So all these things can lead to incontinence that has, you have very little control over, unfortunately. And with dementia, you're at a 3 times higher rate of getting or experiencing incontinence issues. Fecal incontinence is estimated to occur in about 2 to 5% of typical older population, but is probably considerably higher in those who have dementia. Again, they're not reading the signals, right? They're not being notified that this is about to happen. And so it just happens. And they're like, oh, I didn't know, right? I didn't feel that, okay? So we want to ask our doctors about medication that could cause it, okay? Because if that's the culprit, it could be a very simple fix for you, right? You might want to check in again to see if somebody can come and evaluate the home and see if you can put grab rails or other equipment in the toilet to make it easier to that standing and sitting motion. If they're struggling with that, like we talked about earlier, that could also hinder them from getting to the toilet in time, right? Sometimes people will get to the bathroom and then the deed is done before they even start messing with their pants, right? So we want to make that transition easier for our loved ones. Consider using contrasting paint on the toilet door, toilet seat, and adequate lighting, okay? So sometimes people who have dementia can get lost in their own home. So they're looking for the bathroom and they keep running into the kitchen or the bedrooms, right? Because they can't find the bathroom. So this tip is just really kind of like making it easier for them to see the bathroom. Sometimes people will put signs up, right? Because someone with dementia may notice a picture of a toilet but may not be able to read the room or read the word restroom, or forget that that's what the door leads to. But if they see the picture of a toilet, they know that's where they need to go, okay? Of course, we want to check the clothing, right? Are they using a lot of snaps or hooks or buttons that are kind of hard? Sometimes Velcro is our best friend. Ease of access, waistbands, elastic waistbands, things like that. And if they're using pads or like the Depends and things like that, we want to make sure that they're easy to pull up and down so that we can encourage them to go on their own. And maybe even a prompted toileting program with fixed timing schedules, right? So nobody wants to monitor the bathroom behaviors of another person, but it's could definitely lead to some ease of care later on. So if you know, hey, maybe 45 minutes after lunchtime, that's usually when mom needs to go. So we're just going to set a timer and we're just going to go. We don't wait for the signal to be noticed by the person. We just kind of estimate when it's going to happen. So that way we can prompt them because their executive functioning and their sensations are compromised. And so they may not notice, but you will know the timeline better than they will. Okay. And then looking for clues of a full bladder, right? Are they restless? Are they pacing? Are they trying to strip their clothes off? Okay, maybe they're not able to tell you that's what they're doing, but their body language is speaking it loud and clear, okay? Sleep disturbances. I noticed this seems to be more common in caregivers who have loved ones with Parkinson's related dementia, but it is pretty prevalent across the board, okay? We do know that age-related changes are well known, right? When you're a teenager, you're sleeping 12 hours a day. When you're older, you may be sleeping 4 to 6, right? Because your body doesn't need it that much. So that's not a red flag necessarily. But with someone who has dementia, it can be more of an increase prevalence, okay? So it can take longer to fall asleep. Maybe they're waking up more frequently throughout the night, more time spent in that lighter stage of sleep. So it's not that deep restorative sleep. Those are all sleep disturbances. And dementia, especially with Alzheimer's disease, there is reduced sleep efficiency. So that means that they're sleeping the same amount of hours, but their quality of sleep has changed. And the amount of time that they're waking up in the middle of the night. The ability to distinguish night from day can also be a loss in the sleep quality, right? The circadian rhythm is kind of messed up. So, the sun goes down and they seem to brighten up and wake up a lot more. And then in the morning, it's like really hard to get them up and they don't really seem awake till like 1 o'clock in the afternoon, right? That's because that sleep wake cycle is disrupted. And of course, disrupted sleep patterns can really mess up your quality of sleep as well, right? Some people have to sleep with one eye open and one ear to the door because, they don't want their loved one getting up at 4 a.m. and going off to find ice cream and just wandering out the house, right? So, of course, that's going to impact your sleep as well. So, we definitely want to make sure that if sleep issues are problematic for your loved one, that we get that situated so that you can get your sleep prioritized as well, okay? Up to 50% of people with dementia have reported sleeping difficulties. Okay, so this is probably more of a matter of not if, but when is this going to happen. All types of dementia studies indicate that between 20 and 50% of people, they experience sleep disturbances. So again, this is very common. So we want to do some simple things, right? Make sure the room is dark at night. Okay, when the sun starts to go down, close those blinds. When the sun starts to get up, open them. Okay, this is going to help with that circadian rhythm. We want to avoid caffeine and discourage daytime napping where possible. We want to increase exercise and daily walks if that's something we can do. And we want to increase the exposure to natural light during the day. Okay. Of course, I'm not advocating to take somebody elderly out in 100-degree heat for long periods of time, but maybe in the mornings when it's cooler or in the evenings when it's cooler, just a few minutes outside, or even just letting that light in through the windows, make sure that it gets through the retina. That can really help as well. Okay, and we want to try these non-medication solutions first. And if they don't work, we want to definitely talk to the doctor and see if there's something that they can do medically to help your loved ones sleep. Okay, sleep is very, very important for everybody involved. So I think that should be a main priority for everybody caring for anybody, especially with dementia loved ones. All right, we talked about this a little bit, visual disturbances. So a visual dysfunction is just, they can't see as well. They can't determine space as well. They can't navigate their spaces as well because they can't see. And this is not uncommon for people who are older, but also in dementia, because if you remember, dementia affects how we translate the information that comes into the brain. So that includes all of our senses, sight, smell, taste, right? All of that. So maybe their eyes are fine, but the input being translated into the brain is not, okay? But we always want to make sure that we can correct the visual disturbances with glasses, eye drops, dressing cataracts, things like that. So they can experience decreased contrast sensitivity. So their lights and their darks are kind of blurry. So that can prevent them from being able to distinguish objects from the background. Decreased visual acuity. So they can't see things as clearly. Again, things might just be kind of, bland or matte or run together. Partial loss of visual field can occur with people in dementia. So you and I have a pretty, most of us have a pretty healthy peripheral, but people with dementia, it can be very closed. Okay, so they can maybe only see what's right in front of them. They can't see what's around them. So if you notice, if you have a loved one and you kind of walk up behind them, maybe they get a little startled because they didn't see you until you were like almost right in front of them, right? So it can be a little spooky, like, wow, you just appeared out of nowhere, right? So that can definitely become an issue as they try to navigate around the world, right? So we want to be aware that visual impairments can arise due to onset of dementia as well. And of course, if you have lower lights in the house, we want to maybe shift it to maybe a brighter setting so that they can see the shadows and things more clearly. Make sure you're taking your loved one to the optometrist or ophthalmologist to check, do they have glaucoma? Do they have cataracts? That kind of thing. And sometimes, when we go to the eye doctor, we're reading the little sign and we're doing the things like, average people would do. But your loved one may not be able to do that, so they can go in and just look at the actual eye and see the health of the eye with the cataracts and the glaucoma and things like that. So symptoms: blurred and distorted vision, difficulty reading and writing, depth perception can be kind of wonky. They might not be able to recognize known objects, right? They might not be able to see things as well and understand what that is. And then a reduced sensitivity to low light. So again, we want to check the physical eye. We want to check the doctor, see what they say, and then just try to make the atmosphere that your loved one's navigating a bit more friendly to people who are maybe having a hard time seeing. Okay, sometimes people will put like yellow caution tape kind of looking stuff on their stairs each step, so that contrast is easier to see, so they can kind of tell where the steps are. And again, just making sure that there's adequate light. All right, oral disease. So there have been a lot of advances in prevention in dentistry and retention of natural teeth into older age. And so that means a lot more people are going to need oral care as they age. A large proportion of older adults will have dementia, so it's important to establish good oral hygiene and practice dental care for those who are living with it. People with dementia are likely to have fewer natural teeth and increased plaque accumulation and dry mouth. Worldwide studies report an increase in the amount of poor oral hygiene cases in people with dementia. Up to 50% of older people in residential aged care facilities are at a higher risk of oral disease because it's just probably more difficult to have that consistency than it would be if you're living at home, right? So what are some signs? Are they refusing to eat or drink? Okay, so you can see oral disease and nutritional deficiencies can go hand in hand, right? Restlessness or agitation, right? Maybe there's some pain they're experiencing, but they can't tell you that that's what's happening. Drooling, spitting, bleeding from the gums, from the tongue or the cheeks can be an indicator of oral disease. Refusing to brush their teeth, refusing to use mouthwashes, refusing to wear dentures, okay? All of that can be an indicator that they're having some pain or some sensitivities or some discomfort. And then, of course, if their breath is bad, that could also be a sign. So we want to try to brush their teeth regularly, just like we do our own. Have a full assessment of their dental health. So take them to the doctor, take them to the dentist, and then use mouthwash or gel if they're not able to brush their teeth because they're just being really resistant. Of course, we don't want to get bitten. We don't want to cause trauma, but we don't want to leave them uncared for either. So there's other ways we can go about addressing oral hygiene if they're being reluctant to use the toothbrush. Frailty. So I did mention this a little bit before. Frailty is the reduction of your physiological reserve. Okay, so poor physical function, right? You don't have a lot of energy. You don't have a lot of capacity to move your body the way that you used to. Okay. Frailty increases your loved one's risk of functional dependence, institutionalization, and death. So what does that mean? Functional dependence is it just increases their need for you to help because they can't do it themselves. Okay. No single process has been identified to explain frailty, but it is known that frailty increases with age and is more common in women. So features of frailty: weight loss, decreased muscle strength. There's the speed that they're walking kind of slows down a little bit more. They're losing balance. Okay. There is no evidence to suggest that these features are caused by dementia, but they can also occur many years before the onset of dementia. Okay. And if you are around middle age, especially if you're a woman, you might hear in the health spaces, health and wellness spaces, to do load bearing weights, right? Do strength training. It's to prevent frailty in your older years, right? So take that to heed, right? Take that caution because it's not going to guarantee you won't get dementia, but it can definitely increase your chances of it skipping you. Okay. There are more cases of dementia in frail older people than non-frail older people. Okay. So dementia doesn't cause frailty necessarily, but frailty can be linked to dementia. Okay. Frailty increases with age, is more common in women, already said that, and studies indicate that people who have both cognitive impairment and a slow walking speed were 5 times more likely to develop dementia, okay? So when people advocate for you to be active, to walk, to do some low impact strength training, this is why, okay? Strength equals longevity in a lot of ways, not just for dementia, okay? So consider regular exercise, walking, resistance training, strength training, exercises for balance, okay? If weight loss and poor appetite are factors that cause frailty in people with dementia, visiting a dietitian can be helpful. Reading some good books can be helpful. And focusing on nutritional requirements, including supplements where appropriate, okay? So things like calcium, right? Those are good for your bones. Magnesium is good for the brain. B12, that kind of stuff are good for all that, the system, managing the system. All right, so now just my last few slides, we're going to talk about what to expect at each stage of dementia, okay? So this is written in the perspective of like if you were experiencing these symptoms, okay? But of course, they're applicable to a loved one if you're caring for them. So minor problems in the mild stages, right? Maybe you're misplacing things around the home or your loved one's misplacing things around the home. A lot of times people dismiss this as just normal age-related memory loss. And memory tests are unlikely to detect the disease, okay? So this will just be simple things like, you know, I misplaced my keys, I can't find my shoes, that kind of thing. Mild decline, so this is the next stage. This is mild cognitive impairment. So most people are not diagnosed with a dementia with MCI. A lot of times people can get mild cognitive impairment and never develop dementia, okay? So if you're diagnosed with this, I don't want you to freak out, okay? It's not a dementia diagnosis, okay? But it is kind of like a warning sign maybe, or kind of like a, hey, let's pay attention kind of a thing. So friends and family members might begin to notice memory and cognitive problems before you do. You might notice finding a hard time finding the right words during a conversation, remembering names, planning and organizing activities like eating regular meals and cleaning your teeth, so just your basic daily stuff. And performance on memory and cognitive tests is indicating that there is impaired cognitive function, okay? And this might be the stage where your doctor offers you medication. Moderate decline. So this is a further decline noticed by friends and family, right? Or if you're caring for a loved one that you suspect has dementia, you're noticing this about them. But they may not be aware of their memory issues, okay? But people around them are noticing it, right? Difficulty with simple math can prevent them from managing their finances well or pay their bills. There can be an increase in short-term memory loss and loss of details about the past, okay? So you might be like, Mom, we just went to the grocery store yesterday, don't you remember? And then she's like, oh yeah, that's right, right? That kind of thing. Moderately severe decline, so significant confusion for most of the day, with an inability to recall simple details about themselves, like what's your phone number, where do you live, that kind of thing. Some people have difficulty getting dressed appropriately, but can still bathe and toilet independently. So maybe they get lost in a shirt hole, okay? Or maybe they're putting on dirty clothes, or maybe they're putting them on backwards, or maybe they're dressing out of season, okay? Family members will still remain familiar, and some details about the past, especially childhood, can be recalled, okay? And then finally, the last slide here, severe decline. So this is where your loved one is going to need constant supervision, maybe some supportive services. Confusion or unawareness of the surrounding environment increases, right? I don't know where I am. I don't know who I'm with. They may have major personality changes. So difficult behaviors can start to appear at this time. Maybe they're getting more aggressive. Maybe they're getting maybe a little bit more nasty, right? They're maybe calling names or what have you, using language that they never used to use. That can be a big one. They may need more help with daily living activities like toileting and bathing and eating. They may be able to recognize faces or unable to recognize faces unless they're close friends and family. Okay, so a lot of people that they know can suddenly become strangers to them. And of course, the wandering, right? They're not really sure where they're going. They're looking for something specific. Sometimes, if they're living with you at this time, they might be saying, I want to go home because they don't view your home as their home. And then, of course, the incontinence can start coming into play at this point. And then severe decline. So dementia is a terminal illness. And so at the end, we have to expect the total loss of the ability to respond to the environment or to communicate. Some may be able to utter words and phrases, but most have no insight, and full assistance is required for daily activities. Okay, so this is probably where your loved one is unable to move on their own. They're not able to feed themselves. They're not able to engage in a lot of activities. And so the final stages of dementia, they will lose the ability to swallow. Okay, so this can be a very hard time for you, obviously, and people who, they want to still provide food and water and things like that to a loved one because they're like, I don't want them to be hungry. I don't want them to be thirsty. I don't want them to starve to death, like that kind of thing. But it's not uncommon for them to not be able to swallow. So if you give them food, if you give them drink, if you give them medication, that can just make it worse for them, okay, because they can't swallow. So that's the end of my information today. I know I kind of dropped it on a somber note, but this is for educational purposes, and sometimes the things we have to know are not pleasant to know. So I do apologize for kind of dropping you off right here. But again, I hope this information is useful for you going forward. A lot of these things are unavoidable, and so our best course of action is to be made aware and to start planning now on how we can advocate for our loved ones and how we can provide the best care for them so that we're not caught off guard, because we know these stages are coming, okay? And we know these comorbidities can pop up, okay? So it's not just memory decline. There's all these other things that can happen while your loved one is walking through this disease to the end, okay? So education is our friend, even if it hurts to hear sometimes, right? All right, let me stop my share.